This session. In order to earn your CEU, you must watch this session in its entirety and complete the assessment when it pops up at the end. If you do not immediately take the assessment when it appears, you will need to exit the on-demand area, then return and watch the session again to access the assessment. In compliance with continuing education requirements, all presenters must disclose any financial or other associations with companies to which they have a direct link and/or financial relationship that is related to the topic or content of their presentation.
Hello, welcome. Thank you for joining us today. Just a few announcements before we begin. So each day at the end of the convention, you will receive an email inviting you to evaluate the day's speakers and sessions and to assess your learning. Be sure to complete them, as your feedback plays an important part in future programming and in reflecting on your own learning. All handouts that were submitted for the online library are posted on the convention website. New ones will be added as they are provided. And if you can all please take a few moments to silence your cell phone or other devices. And then at time permits, there will be a Q&A session at the end of the event. So please walk up to each of the microphones so that everyone can hear you. This is a recorded lecture, so it's going to be really important that we have the questions over the microphone as well. So my name is Katie Peets. I'm the Clinical Education Coordinator at Washington State University. Our speaker, Julie Freimeyer, is currently entering her 5th season as an assistant athletic trainer and physical therapist for the Kansas City Chiefs. She completed her undergraduate degree in athletic training at Westchester University, master's in exercise physiology at Florida International University, and doctorate in physical therapy at the University of St. Augustine. Julie has worked at Princeton, Towson, and Butler University, working with football, rugby, rowing, women's basketball, and tennis. She was an athletic training coordinator for Naples Community Hospital, where she supervised 8 athletic trainers, updated manuals, and implemented new policies and procedures, all while completing her DPT. Freimeyer has enjoyed being a preceptor her entire career and has taught in numerous athletic training programs as an adjunct professor. Julie is active in PFATs, taking part in the diversity and internal education committees. She was recognized by her peers and asked to co-chair the upper extremity committee within the NFL's musculoskeletal task force, as well as joining the sports med committee. Please join me in welcoming Julie Freimeyer.
Good morning, everybody. So as she said, my name is Julie Freimeyer. I'm an assistant athletic trainer and physical therapist with the Kansas City Chiefs. And today we're going to talk about pathology and diagnosis of cyclic vomiting syndrome and cannabinoid hyperemesis syndrome in NFL players. I don't have any conflicts of interest or any disclosures to disclose at this time. So today we're going to go through and talk about cyclic vomiting syndrome and cannabinoid hyperemesis syndrome. So we are going to define what those are, be able to list the diagnostic criteria for both CVS and CHS, describe the 4 phases that make up CVS and CHS. We're going to be able to talk about the trigger mechanisms for CVS and CHS, describe treatment and medication options for each of those 4 phases in depth, as well as summarize a return to play for athletes after an episode of CVS or CHS. So what is cyclic vomiting syndrome and cannabinoid hyperemesis syndrome? So they are chronic functional brain-gut disorders. So what does that mean? Functional means that there is not a structural or biochemical abnormality. So these are things that would be like tumors, masses, things of that nature. So there's nothing structural that is causing this diagnosis. It is something that is functional, and it's that gut-brain connection. They are characterized by episodes of nausea, vomiting, and abdominal pain. So these are cyclic episodes. They are intense, they are recurring, and they are incapacitating. So when they are in the middle of one of their episodes, they physically cannot stop vomiting. It is something that they are in for hours and even up to days or weeks. They are unable to control the vomiting. They have extreme abdominal pain, what we would call an abdominal migraine, as well as some intense nausea. They might have a cranial migraine. They will have autonomic nervous symptoms that you'll see: sweating, pallor. They can't get comfortable. Like these guys, when they are in the middle of an episode, are curled up in a fetal position, cannot function. Once that episode passes, they get into what we call the asymptomatic period. So this can last for weeks up to months, And at this time, they're pretty much in normal health. So this is that cyclic cycle that they get in. They have an episode of this intense vomiting, and then they get out of the episode, and for all intents and purposes, they're in that asymptomatic period where they're relatively healthy. So as you can see, cyclic vomiting syndrome and cannabinoid hyperemesis syndrome really have the exact same clinical presentations. The only difference with that CHS is that there is a history of chronic cannabis use. When we say chronic cannabis use, they're still not really sure what that is. That's something that they're still trying to look at and still trying to define as what chronic really entails. So again, when we talk a little bit more about these episodes, what are they, when do they happen? The research has shown that they can be about 3 to 70 episodes per year. So again, these can last hours or days. So if you have 70 episodes a year that are lasting multiple days, over half of the year you could be vomiting. On average, they have about 12 episodes per year. A lot of times these episodes will start between midnight and noon. So usually they start in the morning. Most of the time, with our experience with the guys that we have had that have it, they will wake up in an episode. So when they wake up, the first thing, they're going to the bathroom, they're vomiting first thing in the morning. These episodes can cause frequent trips to the emergency room as well as hospitalizations. So we're going to talk about a little bit later, there is a delay in diagnosis with this. So in that delay, they are going to the ER to try to get these episodes managed. And again, if it's not diagnosed at this time, there's going to be a lot of stays in hospitals with a lot of testing, trying to figure out what's going on with them as to why they can't stop vomiting. Again, these episodes are very debilitating, and they can have both economic and social ramifications. So if you think about it, like I said, these episodes are very debilitating. I personally have never seen anything like it in my life until I saw these guys and how they respond to this. They are in our doctor's office in a dark room, literally just trying to get through it. These guys they have nothing left to give when they are throwing up. So think about how long that might last for them. They can't go to work, you can't go to school. So there's your economic ramifications there. Thinking about your social ramifications, obviously it's going to take a toll on your social life. You know, if you keep having these cycles and people aren't going to want to spend time with you, they don't understand what's going on. Think about how it's going to affect your personal life. If you have a significant other, if you have kids aren't going to understand why mommy or daddy can't play with them for a couple days. It's going to be a lot on your partner to be able to help with those things. So again, a lot of social and economic ramifications. And then obviously that's going to affect their quality of life. So some background on cyclic vomiting syndrome. It was first described in the research in 1806, and it was originally looked at in children. So it's more recent finding in adults, probably in the last only like 25 or so years have they really started looking at it in adults. And this is one of the reasons why it has been underdiagnosed and misdiagnosed in adults, because originally they thought it just happened in children. So they have started looking at more research in the adults, and like I said, in probably about the last 25 years. And then the first case of cannabinoid hyperemesis syndrome was first described in the research in 2004 in Australia. So again, a very relatively new diagnosis. As I mentioned, it is that brain-gut disorder. So it's a disturbed regulation between the gut and the brain. And again, it's functional. There's nothing there that is structural that is causing the dysfunction. It is a genetically predisposed condition, so all of the testing that they are going to do is going to come back normal. Some comorbidities that people with cyclic vomiting syndrome will have includes migraines, anxiety, panic attacks, PTSD. So again, you can see that very large psychological component that ties into this. And in adults, you will see some inter-episodic nausea as well. So continuing talking about some background. Most of the studies that you see in cyclic vomiting syndrome are all retrospective studies. So we don't have a lot of studies, or we don't have any studies that are looking at controlled trials with placebos and looking into the future and trying to get some of that evidence. So it is pretty low quality evidence on treatment, and it is a lot based on expert consensus on these retrospective studies. So there is a lack of widespread knowledge within the diagnosis. And again, why it's misdiagnosed and why there's such a delay in getting this diagnosed. It's not something that people are very familiar with. It's not something they see a lot of. In adults, we have an average about 8 years until they get diagnosed. So if you think about that, again, these incapacitating episodes of nausea that they're having, and nobody can tell them why it's happening for 8 years. Obviously, we have, being in the NFL, we'll get players from other teams coming to us from college. We've had some of these guys that come to us and they've had this nausea for years and don't know why. So it is something that in trying to get that diagnosis out there, and if you are seeing it in your athletes, it can really make a difference and really change their lives once somebody gives them the diagnosis and how you can help them. There is an average about 15 ER visits before they will get their diagnosis. And again, with these studies not being of the highest quality, the incidence and how this occurs in the public is pretty varied. You'll see it as low as 2% in the population, and then as high as up to even almost 11%. These are considered periodic disorders. So what they mean by that is that there are these triggers that can ensue an episode. So what you're trying to do is recognize what those triggers may be, and then thereby trying to raise the threshold of that trigger. So as I said, some of these guys will have comorbidities with anxiety, depression. So if you can find these triggers and figure out a way to help them and help treat them, we can take that threshold and raise that threshold to hopefully not have them get as many episodes of that nausea and vomiting. There is a diversity and difference in pathways of how these individuals will get to that episode. So again, noticing those triggers and identifying those triggers in those people is important. There are different subtypes within CVS, which CHS is one of those subtypes. So again, each one of those subtypes would have a different trigger. Looking at the demographics and epidemiology, again, the research is kind of all over the place. It does have a slight increase in Caucasians, but it does occur in all races, ages, and genders. Again, like I said earlier, that incidence range varies a lot per the research, as low as 2% up to even 11%. And one thing they do notice with this is because, again, of the misdiagnosis or being undiagnosed, that there are a lot of surgical procedures that end up happening with these individuals because of undiagnosed CVS. So they, again, present with this intense nausea and vomiting, and they're trying to figure out why and what to do about it. And sometimes they will end up having these surgical procedures, with the most common being appendix and gallbladder removal to try to get this to stop, which we have had in multiple of our players that have lost internal organs due to undiagnosed CVS. So this article looked at a survey of emergency department use in individuals with cyclic vomiting syndrome. So again, just a response study, got about 250 responses. From those 250 individuals, there were almost 2,500 emergency room visits. Half of those hadn't been diagnosed with CVS. So again, a lot of these people going to the ER don't know what they have, and these people don't know how to recognize it and don't know how to treat it. Of those 251 respondents, 89 were people who had protocols from their physicians. So they walked in with a letter saying, this is what I have, this is what I need done to get this to stop. And because of that protocol, about 80% of those were either carried out fully or partially. So that protocol can help them get what they need and help get that recognized while they're in the emergency room. Cyclic vomiting syndrome in adults mimics very closely that in children. So again, like I said, this was first recognized in children, but as you can see here, they pretty much present the same way. There are a few differences between the adults and children. The big ones being that delay in diagnosis. Again, there's still a little bit of a delay in children, but it is less than half the time in adults. So if you look at that on the high end for children, it's about 3 years, and again, on the high end for adults, it's 8 years there. The duration of episodes varies a little bit as well. For children, you're only looking at about 2 days, and then the average for adults is almost double that at 3.8 days. So again, that delay in diagnosis as well as the duration of those episodes. The children don't seem to get any nausea in between their episodes. That is more common in adults. And then the other thing that is different between children and adult presentation is that cannabis use. Obviously, you're not seeing that in children, but they are seeing that in adults. So how do we diagnose CVS and CHS? So there are two diagnostic criteria for CVS. One uses the Rome-4, which looks at functional gastrointestinal disorders. So again, these are disorders that don't have that structural cause. They are more functional in nature. And this book outlines a diagnosis for every single one of them. So again, these are based on expert consensus. The Rome-4 came out in 2016. Prior to that, there was the Rome-3, which was 2006. In 2006 was the first time that CVS was identified in the Rome-3 as a diagnosis with diagnostic criteria. So then it took them 10 years to come up with a revised criteria for CVS. So if you look at their criteria, it is pretty basic. It is 3 discrete episodes in a year, with 2 episodes being in the past 6 months, at least 1 week apart. And then in between those episodes, you're gonna have an absence of vomiting and essentially be relatively healthy. So again, not super descriptive in its diagnostic criteria. The other diagnostic criteria out there is the International Classification of Headache Disorders. This is the 3rd edition. This came out in 2013. So again, this is 2013, the Rome-4 is 2016, so still a little bit outdated with how new that these diagnoses are. Things have changed in that time. This one is a little bit more specific as to what those episodes need to entail for its diagnosis, but again, very similar to the Rome-4. You're looking at attacks of nausea and vomiting. Again, it'll be those recurring and predictable periodically. They will have nausea and vomiting at least 4 times per hour in that attack. Their attacks will last for at least 1 hour and up to 10 days, and they occur at least 1 week apart. So again, like I said, this is just a little bit more descriptive of that episode in general. And then they will be free of symptoms in between, so that interepisodic asymptomatic time frame. So the only diagnostic criteria out there right now for CHS is per the Rome-4. And again, that was done in 2016, and that was the first time something official came out to kind of look at CHS and the diagnosis for cannabinoid hyperemesis syndrome. So as you look at this, you can see it's very similar to CVS. So if you look at starting at number 3 there, with at least 3 episodes in the last year, 2 within the last 6 months, that's identical to what was in the CHS diagnosis, and then no vomiting between episodes. Again, those 2 identical to what was in the CVS diagnosis. This one also looks at symptoms being present for about 3 months, and then their episodes lasting less than a week. So they think that these episodes with the CVS might last a little, or I'm sorry, with the CHS might last a little less in duration than the CVS. But again, as I said, you can see they're very similar in diagnostic criteria to the CVS. And again, this came out in 2016. So to look at the use of the word chronic, like I said, they really don't know how to define chronic right now. This study came out of the Mayo Clinic, and they took 98 patients who were diagnosed with CHS, and they were trying to figure out how much cannabis they used and when they used it. So if you look at the graph on the top, they're looking at the duration, so how many years were they using cannabis? And then if you look at the bottom, it's looking at frequency, so how often were they using cannabis? And as you can see, there's really not a rhyme or reason as to why this affects who it affects. If you look at that top chart with duration, even those who had a longer duration of cannabis use, it's actually a lower percentage compared to those in that 2 to 5. So it is kind of all over the place. And again, which is why they're trying to look at what are we defining and how do we define chronic. And then again, looking at that frequency, it does appear that the daily use has a greater impact compared to some of the lower frequencies there. So this article, The Role of Chronic Cannabis Use, Cyclic Vomiting Syndrome versus Cannabinoid Hyperemesis Syndrome. This was published by a large group of physicians within the Cyclic Vomiting Association. So this came out in 2019, and they were looking to try and update some of the, what they thought to be outdated things with cannabinoid hyperemesis syndrome. So they're trying to say that cannabis hyperemesis syndrome is not a distinct disease. So it is not something that prior to this time, people thought they were two separate entities, that it is not a separate entity, that is actually just a subset of cyclic vomiting syndrome. And you can see why that makes sense, because everything pretty much mimics what they are between the CVS and the CHS and how they present. So they feel that the CHS, that chronic cannabis use, is what unmasks in these predisposed individuals that already have CVS. So again, you're born with this, you already are predisposed to have CVS, and the chronic cannabis use is what kicks you into those episodes. Continuing with this article, they looked at cannabis use and the increase in legalization across the United States and how that has increased the emergency department visits due to cannabis. So between 2006 and 2013 in Colorado, there was a 5.5 times increase of ED visits based off of cannabis. So they were looking at about 13 per 100,000 emergency room visits were due to cannabis. And in 2013 alone, that cost the ED $83 million. So you can see as cannabis started to become more accessible and more mainstream, that did increase the amount of ED visits because of it. That being said, CVS amongst cannabis users is low. Like, I don't want you guys thinking anybody who uses cannabis is going to get chronic vomiting syndrome. So they have found because of that, that CHS is being overdiagnosed per their research. So anybody who has smoked marijuana, anybody who has used cannabis, if you go to an emergency room, now they think you have CHS. So again, they're trying to narrow this down and make it like, again, it's not a separate condition, that this is CVS and these are still the qualifications that you have to meet to be able to be diagnosed with this condition. To be a separate condition, it has to affect a different patient population. And if you look at those that get affected by CVS and those that are affected with CHS, they're the exact same patient population. There is no differentiating clinical features. They present the exact same way, and that they don't have a different response to therapy. So again, if they were different entities, the same treatments wouldn't work. And once we'll get into treatments in a little bit, these people respond the exact same to treatments. The same treatments work for both CVS and CHS. So because of this, again, that stigma of cannabis, there is starting to be a recognition bias in diagnosing some people with this CHS. Congruent with that recognition bias is the hot shower. So I know this sounds weird. However, when these guys, our guys, and just people with cyclic vomiting syndrome in general, when they're in the middle of an episode, hot water is one thing that can calm their symptoms. So when they are sitting in the hot tub or sitting in that hot shower, they don't feel that intense nausea and don't have that urge to vomit. This, for a while, thought to only work for those with cannabinoid hyperemesis syndrome. So this became a stereotypical diagnosis. So anybody who used the shower to help with their symptoms was CHS. They used cannabis and didn't have cyclic vomiting syndrome. However, the research has shown that not all people with CHS report that they use hot showers or that they get relief with it. There are also patients, CVS patients, that have no cannabis history, or there are also children that have used the hot shower. So the hot shower is not pathogenomic of cannabis, so it's not if this then that, and it is neither specific nor sensitive in the diagnosis for cannabinoid hyperemesis syndrome. So there are 4 phases to cyclic vomiting syndrome and cannabinoid hyperemesis syndrome. So they are the interepisodic, the prodrome, emetic, and then the recovery. And we're going to go through each one of those. The prodrome phase is the goal of that phase would be to abort the emetic phase. So this is the time before they would start vomiting. They will say sometimes you can get an aura, much like in a migraine. People will feel something coming on. So they will start to get this aura. They might start to feel nauseous, chills, flush, any type of autonomic nervous symptom, kind of fight or flight response can be something that they can start to feel. I've worked really hard with our guys that we have to try to identify those triggers and identify those auras for them, because if we can get to them, we have been able to abort episodes before they happen. And if you can abort an episode before it happens, it is huge, saves them a lot of stress, saves you a lot of time. So if they can, again, recognize what some of these auras are, then they can, at this point, they can still retain oral meds, so we can give them medicine to try to abort that. As soon as they start vomiting, that's the end of the prodrome phase, and you've entered into the emetic phase. The prodrome phase can last days, minutes, or it can never happen. Like I said, sometimes our guys will wake up and they will be in the middle of an episode, so they never really get that true prodrome phase to be able to get that aura to know what's coming. And the other thing with this is, as I mentioned earlier, it is a gut-brain functional disorder. Anxiety potentiates nausea. These guys know it's coming. They've had it happen before. If they can recognize this aura, they know that the nausea and the vomiting is on its way. So they start to get anxious, and that's going to kick them into their cycle even sooner. So once they actively start vomiting, now you've got into the emetic phase. The goal of the emetic phase is obviously to terminate the vomiting. The vomiting is severe, it's persistent. They will complain of what is called an abdominal migraine. So it is epigastric pain, so just above the stomach. And then obviously the vomiting. Per the research, the vomiting can range from anywhere from 1 time every 2 hours to as much as 20 times in 1 hour. These guys will report intense thirst because, again, they're vomiting so much that they're very thirsty. You can also witness what is called a guzzle and vomit behavior. So again, these guys, they have nothing left in their system when they've already vomited 20 times that hour. So it's not even bile at this point. The way they are vomiting, it is coming from the depths of their soul at this point. So these people will literally just chug a bottle of water to be able to throw up, because that feels better than the vomiting that they have been continually doing when they have nothing left to give. So it's not uncommon to see them, like I said, chug that water, and then they'll throw up after that, which will give them a few minutes of relief, but then that nausea and vomiting kicks back in. I've actually seen guys who will try to alleviate their own nausea by sticking their finger down their throat to try to throw up, to try to feel better. So again, this is a very incapacitating time. They are trying to do anything and everything they can to try and feel better. This would be the phase where, if the hot shower does work for them, getting in the shower or even a hot tub to try to alleviate some of those symptoms. Some of the research articles that I read, there was one person who reported being in a hot shower for 360 out of 365 days of the year because they were so nauseous. So again, these things are very incapacitating. As I said before, I never really saw anything like this. As an athletic trainer, I think we are programmed to want to help and try and make people feel better, and there was nothing we could do at this point to try and make them feel better. So learning about the disease, learning about the diagnosis, learning about the treatments was really our best way to help them, because again, they are in intense distress while they are in the middle of these phases. These phases, or the emetic phase, can stack on top of each other, so they will coalesce. So if they do not get proper treatment and get that emetic phase aborted, they will, what they call, like I said, stack, and they will coalesce. So they will be continuously sick for weeks. And unfortunately, I've had the experience of some of our guys having this as well. So it's nice that now we know what it is, and when they're with us, we can help them. The problem is they aren't always with us. So when they go out of town or they're on vacation or things like that, again, if this isn't recognized wherever they may be, and we have guys going on vacation to foreign countries and different things, they're not able to get the treatment that they need where they are all the time. So we've worked really hard to be able to try to set up different hubs for them. So if we know when they're going to spend time here in the off season or whatever, we'll get with doctors in their hometown and try and make a network for them there. Again, doing those protocols for the EDs, again, trying to get them what they need. But if they don't, again, these episodes will just stack on top of themselves. So we had a guy who was on vacation and was gone for a little over a week and was just in an episode practically the entire time he was there. So when he came back, what treatment we know that works on him, the first time we used it didn't work because he had coalesced and it had stacked on top of it. So we had to use multiple rounds of that treatment to kick him out of his cycle. So obviously if these coalesce, they're going to be unable to attend work, unable to attend school. So again, you have your social and economic ramifications that go with that. And usually, again, it's coalesced because it was untreated. So as you can see, you'll get a lot of complications from the emetic phase if it isn't treated properly. So these are just some of those complications that you could get with hypovolemic shock, electrolyte depletion, obviously, tetany, some blood in your vomit, gastritis, again, neutrophilia. So this is where that white blood cell, your body's trying to do something, so the white blood cell count will go up, and this is where sometimes people will be losing organs because it looks like they have some sort of infection. So again, that's where the appendix comes in, the gallbladder, and then you can also get acute renal failure, again, from the electrolyte depletion if this isn't treated. Then we get into the recovery phase. So after you have successfully aborted the emetic phase, they have stopped vomiting. Now we're in the recovery phase. So this is when they start to get an appetite and they will be able to tolerate food again and essentially return to what they know as normal life. This is when you start your prophylactic medications again. And this recovery phase can vary based off of how long their emetic phase may last. And if you don't kind of tread carefully and lightly in the recovery phase, you can kick them back into their emetic phase. So if they start to eat too quickly, if they start to do too much too quickly, they can go back into that emetic phase. So in this recovery phase, we're really just trying to make an environment that is conducive to keep them feeling good and moving forward with their asymptomatic period. And then this is also where you want to address any of those imbalances that they may have had from their emetic phase with the fluid loss, the electrolyte imbalance. We have guys that will have problem with weight loss, obviously, during these episodes as well. So trying to get that weight back up. So looking at the pathophysiology, why does this happen in people? And the short answer is they're not really sure. It is complex and multifactorial, but the etiology is unknown at this time. They do have some theories and think there are some different things that can play into it. One of them being the endocannabinoid system, which is in all of us and involved in CVS. They do feel that it could be a manifestation of a migraine, which is also part of a mitochondrial defect, and that it can also be an autonomic neuron or neuroendocrine dysfunction. So again, those psychological components that come into it. And they have looked some at some gastrointestinal dysrhythmias, but the research is all over the place. Some people with CVS will have a slowed gut motility, and some will have increased gut motility. So there's really no clear-cut answer one way or the other there. So when we talk about the endocannabinoid system, we have both CB1 and CB2 receptors in both our brain and our gut. So I'm sure many of you have heard of cannabis being used as an anti-emetic, right? So it'll be used with cancer patients to try and help with their nausea after they go through their chemo. So how can it be both an anti-emetic as well as an emetic for some of these individuals? So with the chronic cannabis use, you're looking at that THC to CBD ratio. They do feel that that ratio has increased over the last couple of years, so you're getting a higher toxicity, which might also be why you're seeing more of this, and why, again, they think this is just a subtype, a variant of CVS, and that you are predisposed to having this, that it's not something different. When looking at that THC, it is absorbed and those receptors in the brain are what interact with that first. So that's when it's an antiemetic. The CB1s bind with that, and that is when it is an antiemetic. With the chronic overuse, the CB1s start to downregulate in the brain, and now they're not absorbing it first, and now the CB2s in the gut are absorbing it, and that is when it becomes an emetic. So CB1's absorption is when it's an antiemetic, downregulates with chronic use, and the CB2s start to absorb, and that's when it becomes an emetic. The other pathophysiology is the migraine component. So they do think that there is a manifestation of migraine from the maternal side, and they have identified some mitochondrial abnormalities within that migraine component. All of our guys that we have diagnosed with CVS and CHS do have a migraine component. They have it themselves, as well as either their mother or a sibling on their mother's side that has a history of migraines. And then the other pathway is the neuroendocrine and the psychological pathway. So again, this is that gut-brain disorder. So it is activated by stressors, and that all starts within the hypothalamus. So that autonomic response gives you a visceral response to stress in the gut. So the hypothalamus secretes excessive CRF, and that altered CRF is what triggers that emesis. So again, that's where that gut-brain relationship comes in. When you're looking at diagnosing CVS, it is a diagnosis of exclusion. So it's kind of like fibromyalgia, to link it to a orthopedic condition. You're pretty much excluding everything else that there is through your history, through all of your testing, and then that's how you come up with the CVS, because all of your testing will be normal when you are looking at all of the labs, as well as radiological testing and EGDs and things of that nature. So the things that we're trying to rule out are any GI disorders, urological disorders, neurological disorders, as well as endocrine. For your reference, here's a very large list of things that we are excluding when we're looking at differential diagnosis, and this runs the gamut here. I mean, you have things from gastritis on here all the way down to brain tumors as to what you are ruling out before you come to your diagnosis of CVS. And then how do we get that diagnosis? How do we rule them out? So here is the gamut of tests that you can perform. A lot of that, again, starting with a history. They're going to describe to you these episodes. Like, you'll start to hear it. You'll see the pattern. So that history is a big tell. Your labs, we do yearly labs on everybody. Everything always comes back normal. We've done EGDs on our guys. Endoscopic testing, we've done ultrasounds, we did CTs, we did gastric emptying test, we looked at brain MRIs as well. And again, every single test that we ran on every single one of these guys came back normal. Which again, you can think about for these individuals how frustrating that is if they're with somebody that doesn't know what cyclic vomiting syndrome is or cannabinoid hyperemesis syndrome. So every test comes back normal. Nobody can tell them what's wrong with them, but they know they have a very real condition when they can't stop throwing up. So when we start looking at treatment, again, as I mentioned earlier, all of our studies for CVS are retrospective studies, so we don't have any placebo-controlled, randomized controlled trials at this time. So again, these treatments are based on general expert consensus. We do know that you have to individualize each one of these treatments. Our guys that we have identified are on similar treatments, but again, on different treatments and what works for them. And some of that is unfortunately just trial and error to figure out what works best for them. And some of that, again, will be dictated by what their triggers are. So again, if you can identify those triggers and how you can treat those triggers, will help you identify how you're going to treat. And then the big thing is the psychological component, because again, as I said, there is a huge anxiety, panic disorders, depression, PTSD that is involved with this as well. So you need to get not only them the psychological support, but again, you can imagine how much this affects the people around them and their family members. So getting support for the family as well. So when we look at our treatment algorithm for CVS, our treatment will be based on what phase they are in. So every phase we're going to approach a little bit differently. So for your general approach, you want to, like I said, identify what those triggers are and try to treat those triggers. You want to try and treat those comorbidities. So if you have identified depression as a comorbidity, trying to get them treatment for the depression. If diabetes is a comorbidity, make sure that we have controlled diabetes. So again, treating those comorbidities with prophylactic medications, and then going down and assessing the severity. So if they have mild, which they're classifying as less than 4 episodes versus greater than 4 episodes, how much prophylactic treatment you need to do with these individuals. So we look at the prodromal phase, which is that phase right before they start vomiting. So if they get that aura of, I know an episode is coming. So again, our goal of that is to abort the episode of vomiting and avoid that emetic phase. So during this time, you're going to treat them with whatever their triggers are. So again, looking at your antiemetic agents. So if they're complaining of nausea, you're going to try to give them something to make the nausea go away. If they're complaining of a headache or a migraine, you're going to try to give something to make the migraine go away. If they're complaining of abdominal pain, you're going to try to give them something for that abdominal pain to go away. So again, you're going to try and give them something based off of what they're presenting with and what their triggers are. So for us, we will use a Prepitant, which is an antiemetic. We found this to work really well for us in that trying to abort that nausea. And then again, all of our guys have a migraine component, so we have used sumatriptan as a way to try and combat the migraine. So the two of these in combination have worked well for us in aborting an episode if they can notice those triggers. This is a very exhaustive list of medications that have been used in the prodromal phase. When I went through the research for this presentation, I went through about 30 to 40 different articles, and everybody's using different medicines, and they're using the names of these medicines interchangeably. So for me, to make it make more sense, I made it into this chart, and it's more a reference point for you to be able to talk with your physicians and talk about what might work for your individual athletes, because again, there is a gamut of drugs up here. And different ones are going to work different for each individual. So again, trying to figure out what works well for that individual. And again, with the mindset of during this prodromal phase, we're trying to prevent them from getting into that emetic phase. So the big ones in this are the antiemetics, again, looking at decreasing any pain they might have, as well as the migraine component. So once you get into that emetic phase, and again, that is when they are actively vomiting, the goal of this is to terminate the vomiting quickly. So at this point, because they are vomiting, they're not going to be able to retain oral meds. So the meds that we give during this time will be given through IV. So our docs will start an IV. We usually do dextrose with that because, again, if there's a mitochondrial disorder, they are in an energy crisis. So the dextrose will help give some energy. We will also, at this point, give any sort of antipsychotic, antiemetic, any sort of med that we need to give them, we will put through the IV. The best treatment once they get into this emetic phase is oftentimes sedation. If they are sleeping, they cannot vomit. So if you can get them sedated to the point where it's almost like you're pressing reset on their body. So you get them sedated, and then in the meantime of them being sedated, you treat all of those symptoms. So you're giving them the antiemetic, you're giving them the pain meds so that when they wake back up, those symptoms are gone and hopefully their body is reset and out of that emetic phase. Again, just for your reference, another very exhaustive list of medications that have been used in the treatment in the emetic phase. And again, it's usually what you have to figure out what works for your individual. So again, working with your physicians and being able to present this to them. And this is literally how I presented it to our physicians as well. I went through, found the research on what people were using, talked with them about what we thought could work for our guys. And again, it was trial and error of what worked and what didn't work. For us, we usually do in this phase a combination of an antiemetic that aprepitant that I was talking about earlier. That is one that you can put through the IV, so it's a solution you mix. That is a pretty powerful antiemetic that has also been used in cancer patients for their nausea with chemo. We found that to work a lot better. We don't really have a lot of success with the Zofrans, the Phenegrins, the promethazines, things of that nature. We found that we need that stronger, different antiemetic using some sort of antidepressant, which is where we will get our sedation from. So something like lorazepam will help with getting the sedation. And then again, something for pain. So again, that will vary depending on the individual as far as what their abdominal pain is at that time. But there, again, you can see some options that you have with Toradol, Dilaudid, hydrocodone, things like that. So again, those phase 3 complications, if you can't get them treated quickly and you can't get those things to stop, so let's say you can't get them those medications, you can't get them sedated, again, these are all those things that can happen if they continuously vomit with your hypovolemic shock, your electrolyte depletion. So again, the sooner you can get that to stop, the better. When we're looking at our treatment for in-between episodes, so this would be our prophylactic treatment. So how can we try to decrease the amount of episodes that they are having? And as I said, they don't have great studies with research backing what these medications should be, but they have found one that works the best as a prophylactic would be the tricyclic antidepressants. For whatever reason, these work really well with these individuals and trying to decrease their episodes per year. They have, in their retrospective studies, found that those who have gone on the tricyclic antidepressants have been able to decrease their amount of episodes per year. So again, this is a first line of defense for us with our guys while they are in their prophylactic treatment. Again, identify what their triggers are and treat their triggers. So if they have a migraine component, treat the migraine. At this point, different individuals might need anti-epileptic drugs, your PPIs, so your proton pump inhibitors. So these are some of the drugs that we have identified that work well for our players. Like I said, we do have our guys on some sort of tricyclic antidepressant. They're not all on the same one. Again, it has been a trial and error process to see how they respond to different ones. Pantoprazole has been one that has worked for us. So again, with that vomiting, they'll get a lot of gastric reflux and GERD, so that helps kind of neutralize that for us. And then the Ajovy, which is an anti-migraine, has worked well for us. If you think about it, these are 20-something-year-old guys who really don't like taking that many medications. The Ajovy is an injectable for the migraine, so you can do that either once a month or once every 3 months. So it just kind of helps decrease how many pills these guys have to take, and some of them like that better. They don't like having to take that many pills all the time. And then here again is your very exhaustive list of medications for your prophylactic treatments as well. And I know I sound like a broken record, but identify your triggers and treat your triggers, and that's how these guys are, or your athletes will respond. So we talked a lot about triggers. Here is just a very brief list of what some of those triggers might be, and essentially the bottom line is stress. Anything that causes stress to the body can be a trigger. So again, any sort of noxious stress, psychological stress, physical stress, not getting sleep. If you think about our athletes, obviously they're going to be under physical duress a lot. Think about preseason, think about things before a game. Any of those things might be triggers. They have shown that even pleasant excitement can kick somebody into a cycle. For women, your menstrual cycle can kick you into an episode of nausea and vomiting. So again, just anything that's going to stress the body could be a trigger. So when you look at cannabis use and CVS, and I kind of touched on this a little bit earlier, it is a little bit sensitive. Like, obviously, there's a stigma around cannabis use, and part of the stigma within that CHS diagnosis is, well, they did this, they brought it on themselves. And there are physicians who don't help them. They aren't recognizing this as a component of CVS, so they aren't giving them those abortive medicines that we give those patients with classic CVS. So there is this stigmatizing recognition bias when they are treating those that have been identified with CHS. So again, just you need to have rapport with your care team, you need to educate, and at the end of the day, like, yes, if they have a cannabis problem, we want to help them with that, but it doesn't matter. If they're in the middle of an episode, we need to stop the episode regardless of what the cause is. So when we identified that we had some individuals with this, I started looking for research, and there was absolutely no recommendations. There was not a case study. There was nothing out there of an athlete ever having CVS and ever playing with it. So we were kind of going in blind as to what to do as far as not just the treatment, but how to get them back after an episode. So after an episode, I feel like this sounds very simple, but your do's and don'ts, again, you want to get them back into their prophylactic meds. You want to start very, very slowly. So they have been vomiting potentially for hours. You are literally starting with small sips of water and Gatorade for the first hour. If you do too much too quickly, they will go back into a emetic phase. And I am telling you this from experience because we had to find it out the hard way. So you have to start very slowly and progress very slowly with their diet. So again, the brat diet, it's going to make their stools firmer. It's going to be very bland and not irritate the stomach. So your don'ts, essentially staying away from things, anything GERD related. So not eating too much too quickly, no citrus, milk, spicy foods. So pretty much everything our guys, again, as 20-somethings want to eat. And again, they have kicked themselves back into cycles by going back to these things too quickly. So again, just that brat diet that we start with, the things that we're avoiding and trying to educate these guys on how they need to start and what foods they need to start with. And again, when we look at that return to play, I don't have steadfast rules for you. It kind of depends on that emetic phase, how long it lasts and how quickly you can get it terminated. So the sooner you get it terminated, essentially the sooner you can potentially get them back. So you're going to, again, start very slowly with this. Again, speaking from experience, we have kicked our guys back into cycles when they have started too quickly, especially during a preseason camp, when things are hot, when they have a lot of stress. So again, you just have to start adding. So add that time slowly, add that intensity slowly, and as they tolerate that, you can start to add more and more back into that. And again, your goal, not to kick them back into that emetic phase. So for our long-term treatments, we're looking at, again, trying to get them that letter from our physician. So if they go outside of us, that they have a plan of care in place. So they can give that to wherever they are and say, this is what I have, this is what I need. Will it work? Maybe, maybe not. Again, you're still at the discretion of that physician, that ED, to take that and use that. But again, trying to equip them the best you can when they are not with you. Again, educating your physicians. If you think you have somebody, a lot of these physicians haven't heard of it. I mean, again, I hadn't heard of it. I had to work very closely with our doctors to get our plan of care in place for these guys. The sooner you can get them treatment, the better. Again, you want to abort that emetic phase as soon as you can. And even if, again, if you can identify those triggers, not even let them get into that in that prodromal phase. Address their comorbidities. So again, broken record with the psychological component that is involved, but make sure you address the psychological needs that they have. A lot of times there will be some depression, PTSD. Make sure you're getting them the help that they need. And again, that long-term prophylactic treatment. So figure out what's going to work for them to be able to try and decrease the amount of episodes that they're going to have throughout the year. The Cyclic Vomiting Syndrome Association, here's the website. They have a plethora of resources for individuals who have cyclic vomiting syndrome, for the families of those with cyclic vomiting syndrome. They have a physician section. They have a resource section as far as trying to get you with physicians in the area that have resources for cyclic vomiting. So this is one of the most exhaustive sites for cyclic vomiting. So that can be a great resource for you. All of my references. And again, I know you guys have a lot of options with who you're going to go listen to, so I thank you guys for all coming and listening and learning about cyclic vomiting syndrome and cannabinoid hyperemesis syndrome. And in the great words of Andy Reid, with that, the time is yours.